Neonate Bell stage 1 necrotizing disease treatment. So Bell stage 1 is divided into A and B, and you see for systemic signs, abdominal signs, radiographical signs, and treatment. So A, B is almost same. The only difference is that in one A you have heme positive stool, whereas in B you will have grossly bloody stool. That is the only difference between A and B. The treatment for both is nil per oral, antibiotics for 3 days. Nil per oral, antibiotics for 3 days. Let's do stage 3 as well. Uh, Stage 3 is it has systemic signs. It has abdominal signs in the form of peritonitis. And the difference between A and B, 3A and 3B, is that 3B will have pneumoperitoneum. What is the treatment for stage 3? Nil per oral, antibiotics for 14 days, fluid resuscitation, inotropic support, ventilator therapy, paracentesis. And in 3B, surgery, because we are suspecting perforation. So here it is one, not mention A or B. So the treatment for both is nil per oral for antibiotics for 3 days. So option number one. A newborn was diagnosed with hepatomegaly during a routine checkup. Soon after birth, the remainder of the exam was largely ordinary. Investigation revealed that anti-HCMV antibodies were present. What is the long-term consequences that this youngster will face? So HCMV antibodies is human cytomegalovirus antibodies that are positive at birth and indicative of congenital infection of CMV that is not symptomatic. The risk of mental retardation is higher in children who have symptoms of CMV infection, while the chances of sensorineural hearing loss is higher in asymptomatic children. So when your anti-HCMV, that is anti-AIDS cytomegalovirus antibodies are present, child normal, you'll have sensorineural hearing loss. Child abnormal, you'll have mental retardation. So here the child is normal, so you'll mark sensorineural hearing loss. A newborn was 6 days old and 2,800 grams at birth, was brought in with complaints of fever, poor feeling, ineffective activity. Both vomiting and diarrhea are absent. The child has 39-degree accelerated temperature, sunken eyes, depressed fontanelle, decreased urine output, and decreased skin turgor. Her mother also had a history of producing less milk and giving top feeds only. What is a likely cause for the above? It sounds like neonatal sepsis. What is the a low birth weight newborn with poor breastfeeding history, fever without presence of diarrhea, vomiting points toward late onset neonatal sepsis. Fever without diarrhea and vomiting points towards neonatal sepsis. Causative organism Klebsiella, more common than Staph aureus. Second most common cause of neonatal mortality after prematurity. Diagnosis is made on clinical basis and along with bacteremia in first month of life. Sepsis occurring within 72 hours of birth is transmitted from the mother's birth canal during birth and leads to early onset pneumonia. Late onset sepsis is defined as onset 22 hours after birth. It is a hospital acquired due to negligence in maintaining cleanliness, seen more frequently in low birth weight and preterm babies or those who are not breastfed. It mostly manifests as septicemia or meningitis. Treatment should be started immediately after taking blood samples for culture and testing. A combination of ampicillin for gram positive and amikacin for gram negative is given. What is the treatment given? A combination of ampicillin for gram positive and amikacin for gram negative is given. Other antibiotics like cephalosporin, cloxacillin, and vancomycin are added if no response is observed. So sepsis screen, 5 components of sepsis screen. Total leukocytes count less than 5,000. Absolute neutrophil count less than 1,800. Total immature neutrophils more than 20%. Micro ESR more than 15. CRP more than 1 milligram per DL. So TLC will be less than 5,000. Neutrophil count less than 1,800. Immature neutrophils more than 20%. ESR more than 15. CRP more than 1 milligram per deciliter. So here, the presence of fever without vomiting and diarrhea is going towards neonatal sepsis. A neonate who had hypoplasia in all of his forelimbs and cicatrizing skin sores all over his body presents to you. Brain MRI shows generalized cerebral atrophy. The results of ophthalmologic fundus examination shows chorioretinitis, which has the highest likelihood of being positive. It could be anti-VZV antibody. This is a congenital varicella infection. Can be suspected on the basis of cicatricial skin lesions, limb hypoplasia, and congenital torch infection. What degree of temperature should be provided for newborns in the delivery room? 25 to 28 degrees Celsius. Ponderal index is weight divided by cube of the height in centimeters. What is the ideal route of drug delivery in neonatal resuscitation? It is through umbilical vein. Umbilical vein. On the first day of life, a neonate shows signs of jaundice. His mother is O negative. How will the patient be treated by you? Phototherapy. On the first day of life, jaundice, phototherapy. So DEXA is hexa. So hexa is a less number, so 4 doses, but it's not 24 hours apart. So this option is wrong. Beta is 12 milligrams, so dose is correct. It's 2 doses, that's correct. 2 doses 12 hours apart, and 1 and 4 are the. So it's not 12 hours apart, it's 12 hours apart, 24 hours. So this is second one is the correct option. Beta methazone 12 milligrams, 24 hours apart. In a primary gravida gives birth to 1410 gram neonate at 32 weeks, preterm baby, preterm labor. The infant's vitals were stable and resuscitation was not required at birth. The infant was moved to an ICU for care. How can we manage the infant's feeding? Answer is start total enteral feeding and IV feeding is not required. A 32 weeks preterm infant weighing 1400 grams with stable vitals in INICU should be kept on enteral nutrition. IV fluids nutrition is not required. Less than 28 weeks, inadequate sucking efforts, impaired gut motility, so TPN. 28 to 31 weeks, sucking burst develop, lack of coordination between suck, swallow, and breathing, nasogastric or orogastric tube. 32 weeks onwards, slightly mature sucking pattern. Coordination begins between suck, swallow, breathing patterns. 30 to 34. Uh, Palladi or cutlery spoon, and more than 34 weeks. direct breastfeeding. So this is how we will remember. Up till 28 weeks, no sucking reflex, no swallowing reflex. You will give TPN. Then coming between 31 to 32 weeks, right? 28 to 31 weeks. That is the 28 to 32 weeks. There is some sucking reflex, and but there is no swallowing reflex. So you will give nasogastric tube. After that, coming to 32 to 34 weeks, here sucking and swallowing reflex presence, we will give Katori Paladai feeding. In more than 34 weeks, baby. 34 is when also the lungs are mature. You will give direct breastfeeding. So here our baby is 32 weeks. That is the limit for starting Katori Paladai Jovi feeding. I have stable, so we'll give total entering feeding and IV is not needed. Seizures are more common in stage 2, whereas the baby is more drowsy in stage 3. So here they have mentioned 2 seizures already. So baby is still in stage number 2. Moro's asymmetrical reflex at birth indicate Erb's palsy. Moro's asymmetrical reflex can be seen in congenital hemiplegia, Erb's palsy, fractured clavicle, shoulder dislocation. Most common fungal infection transmitted by health caregivers to neonates is Candida parapsilosis. Candida parapsilosis is an emerging major human pathogen that has dramatically increased in significance and prevalence over the past 2 decades. That Candida parapsilosis is now one of the leading causes of invasive candidial disease in neonates. Most common non-albicans cause of invasive candidiasis. Multiple studies suggest Candida parapsilosis is primarily a nosocomial pathogen associated with colonization of healthcare workers' hand, while Candida albicans is acquired from maternal genital tract. Candida parapsilosis infections are also especially associated with TPN and its preparations, total parenteral nutrition and its preparations. Parapsilosis is emerging. This is a controversial question. Most common worldwide group beta streptococcus, India, Klebsiella, and early onset is Streptococcus agalactia. Grand general tonic-clonic seizure develops in premature newborn aged 2 years, 2 days. What investigation can be done is transcranial ultrasound. Ultrasonography is ideal for studying newborns. Carried at bedside and offers an accurate measurement of ventricles and other fluid-containing lesions, as well as accurate observation for hemorrhagic and ischemic lesions in their development. Transcranial ultrasound can be done due to the presence of fontanelles. Answer is a baby born at 28 weeks of gestation. To check for retinopathy of prematurity. So the cutoff is 32 weeks and 1.5 kgs. If less than that are exposed to oxygen, then this can occur 32 weeks and less than 1.5 weeks. Answer is esophageal atresia, Klebsiella. This is a controversial question. Answer given by Ames is Acinetobacter. Easy question. Answer is number 4. Answer is born to HIV positive mother. Posterior urethral valve. Lumirubin. All of this. E. coli. 0 to 2 months E. coli. 2 months to 2 years H. influenzae. 2 to 20 years meningococcus pneumococcus. Newborn will come to 0 to 2 months, so E. coli. No shivering. First mouth and then nose. A 3-year-old child can do it. A 3-year-old child knows their name and gender and feeds without spilling. Earlier, we learned that they can feed themselves with a spoon, they can dress themselves, they can run, balance. And now we are learning that they know their name and gender. 3-year-old child. 4 is the score. 3. Tetralogy of Fallot. Phenobarbital. Phenobarbital is the drug of choice in case of neonatal seizures. Loading dose is 20 milligram per kg. Additional 5 to 10 milligram per kg can be given. And then maintenance dose of 3 to 6 milligram per kg is given. Air bronchograms are seen on chest X-ray. As soon as possible. Human donor milk. Improvement in heart rate is the best. The best indicator for adequacy of ventilation in neonatal resuscitation, according to NRP, is improvement in heart rate. The baby's heart rate increases or improves. Correct statement is optimal sample is a urine sample within 2 to 3 weeks after birth. Painful genital ulcers. Herpes simplex. Hypotonia. Criteria for perinatal asphyxia. Neonatal multi-organ damage, dysfunction, neurological manifestations such as coma, lethargy, hypotonia, seizures, HIE in immediate neonatal period, EPGAR score 0 to 3 for more than 5 minutes, umbilical cord arterial pH less than 7. What is the criteria for perinatal asphyxia? Neonatal multi-organ dysfunction, signs of hypoxia such as coma, lethargy, hypotonia, seizures, HIE, EPGAR score of 0 to 3 in more than 5 minutes, umbilical cord arterial pH less than 7. So, hypotonia is a neurological manifestation of hypoxia. PPV, bag and mask ventilation is contraindicated. A baby should not be giving self-inflating O2 bag. Respiratory distress in the newborn. INSURE stands for intubate, intratracheal surfactant, administration, extubation. No intratracheal suctioning. That shouldn't be the answer. Bookworm. Acute rheumatic fever and acute glomerulonephritis. Acute epiglottitis. Twenty ml per kg of 0.9 normal saline isotonic fluid. Parvovirus. Zika virus. Mosquito to human. Sexual. Human to mosquito. Mother to baby. Zika virus. Severe microcephaly. Shigella. Bloody diarrhea. So what is correct? 24 hours after starting antibiotics.